risks that I've never heard of before.
There is a risk, but it's like above what they call the 99-year floodplain. So there's like a little peninsula straight across that floods all the time, and they're talking about putting houses.
Can you help me with this? Because I'm not a computer.
Build a house there. They're going to put it on stilts and things. But about that time, when this was all being debated at the city council and things, we hit the recession, so I think it's been put on the back burner. But I think they did finally give the guy permission to build a few, even though it's in the floodplain. Now they think they put something in it. I guess it's a debate of the flooding versus how much business and new income and stuff they want to bring in. I think it's a bad idea. I disagree with the city council.
Oh yeah, this is installed the driver.
But I'll make it free.
You can either oh, you want the okay. Now if you want to make this one if you don't need that, we can probably better here.
Well, good morning, everyone. Good morning. It's my pleasure today to introduce our speaker, all the way from the Wesley Neurology Clinic over in Memphis, Tennessee, Dr. Gregory Condom. He's, just to give you a little brief synopsis of his career, which has been long. He's had, he trained at the University of Tennessee and did his medical school there and neurology training. And he has fellowship training in EEG and epilepsy monitoring. He's worked in numerous jobs throughout Memphis, but also in places in North Dakota and Mississippi. So he's had a wide and varied career. During this time in Memphis, he's been associated at least off and on with the University of Tennessee and has been teaching residents and students there. His interests are many. He's a general neurologist like myself, but some of the things that he's most interested in are obviously EEG and epilepsy, as well as headaches. He also has a big interest in nutrition and the nervous system. And that brings us to our topic today, which is Wernicke's disease. The last thing I want to say about Dr. Condon is he spent 20 years in the U.S. Army. So we salute him for that. So I welcome Dr. Condon.
If I was sitting in your place, the first thing I would be thinking is, why do we want to talk about this? This is simple stuff. Everybody knows it, right? Well, no. I'm going to give you, at the beginning, some things to remember. One of the biggest things to remember is that you don't have to be an alcoholic to develop Wernicke's disease. Now, most of the people you see who have Wernicke's disease, for various reasons, will be alcoholics. But it's very important to remember that you can get Wernicke's disease for a lot of reasons. We'll talk about that at some length. The other thing to remember in terms of clinical presentation is that Wernicke's disease may not have the classical symptoms or signs. We all memorized MOAN, mental status change, ataxia, nystagmus, etc. But in many cases, none of these actual symptoms are present. So what winds up is that you have to be aware of the risk factors, and you have to have a high level of clinical suspicion.
Oh, if you hit this little gizmo down here, this little thing.
You want it bigger?
No, the next one.
Yeah.
Oh, what does that happen?
What happened there?
Oh, just move the mouse. Yeah.
You got it.
All right. There's a couple of, well, there's one particular paper I'm going to show you and discuss about the fact that Wernicke's disease is probably markedly underdiagnosed. This is a paper that was done in 1986 in Australia, and what it is a retrospective study of patients who had autopsy-proven Wernicke's disease and a comparison between these patients and the clinical presentation during life. It's quite disturbing in some ways. The other thing to remember is that Wernicke's disease is not trivial. When Wernicke's disease was first described by Dr. Wernicke, it was considered to be invariably fatal and was in fact invariably fatal for a long time. In those days, no one knew anything about vitamins, and it turns out that thiamine is a very important thing in the history of nutritional medicine. It's the first of the vitamins that were actually described, and we'll go through that in some length. I'd like to start a little bit with the history. There were 3 index cases described by Dr. Wernicke in about 1883. And he thought that this was not a nutritional problem. He thought it was an inflammatory disease of brain. And he called it the acute hemorrhagic superior polioencephalitis. And for many years, as people described cases of this, they always described it in terms of people who had died from it. Let's start with, let's see, I think we've got to get to the
If you just press the space bar, it'll go to the next one.
space bar. Is that the thing at the bottom?
Yeah. On the keyboard.
On the keyboard.
It
Why don't we have the
should.
keyboard?
Oh, where'd it go?
Here we go. Okay. Let's talk a little bit about factors that influence the development of Wernicke's disease. First of all, there's thiamine intake. It's possible to have a diet that's very, very deficient in thiamine. And in Asia, where the diet tends to be a lot of polished rice, this was very common. There are, in fact, also rather rare genetic abnormalities of thiamine requiring enzyme systems. These are something that you probably will never see. Carbohydrate intake is a big part of it. Stress is usually a part of it. Magnesium and phosphate availability are a part of it because thiamine has to be pyrophosphorylated in order to function. And if magnesium is very low or phosphate's low, it's kind of hard to do that. And then finally, liver disease. The pyrophosphorylation usually occurs in the liver, and that's also where most of the storage occurs. We talked a little bit about the idea that MOAN is not really the diagnostic criteria anymore. rarely will you see anyone who has all four of these. And in a substantial number of people, they don't have any of them. These are some other symptoms that have been found in Wernicke's disease. Encephalopathy of undetermined etiology, amblyopia, pupillary changes, retinal hemorrhage, papilledema, vision loss or hearing loss, fatigability, apathy, irritability, drowsiness. Sleep apnea seems to be associated with it for some reason. Stupor, lactic acidosis, memory impairment can be very prominent with the amnestic dementia of Korsakoff, which is basically just a progression of Wernicke's disease. Depression, psychosis, hypothermia, polyneuropathy, and hyperhidrosis. Now, there are a number of non-alcoholic conditions associated with Wernicke's disease. We'll talk today actually about an actual case of prolonged intravenous feeding that actually caused it. Intravenous hyperalimentation can be an issue because sometimes the hyperal formulas don't contain enough thiamine. Hyperemesis gravidarum, if it's really bad, you can have a problem with this. I saw a patient recently with anorexia nervosa who had lost a huge amount of weight, and she had neuropathy, and she had some other issues cognitively. And one of the things that we supplemented, of course, was thiamine. There are people who is either part of the religious experience or simply a dietary experience do prolonged fasting. The same thing occurs. It's just they don't get the thiamine. There's an interesting problem with refeeding after starvation. And after World War II, when the prisoners of the Japanese were freed, a terrible thing happened. As they started to refeed them, they noticed that a lot of them were simply dropping dead. And what this was giving someone a high carbohydrate load who essentially had no thiamine, and they were precipitating in acute Wernicke's. And they died basically of high output cardiac failure, low peripheral resistance, and loss of autonomic function. Hypothermia is part of that problem too. Gastric glycation can impair absorption. There's an interesting case I'm going to talk about where high-dose prolonged IV nitroglycerin, which actually had an alcohol and polyethylene glycol carrier, precipitated an acute Wernicke's in a man who had been admitted for cardiac disease and had an acute coronary artery problem. Hemodialysis and peritoneal dialysis can be an issue. We don't see this much, gamma hydroxybutyrate abuse. I actually do a fair amount of sleep, and we have a lot of narcoleptics, and one of the things we use to treat that is gamma hydroxybutyrate. Chemotherapy can cause problems, cancer, AIDS, infections, and any sort of chronic inflammatory state. So although the vast number of the people that you will see with Wernicke's will be alcoholic, especially in the context of the VA, it's very important to understand that there are other people who can have this problem. And remember, it's not a trivial problem. You could die from this. And you can have irreversible amnestic dementia, Korsakoff syndrome, from it. There are also some thiamine-responsive inborn errors of metabolism which respond to pharmacologic doses of thiamine. There's a form of megaloblastic anemia that does, lactic acidosis sometimes, branched chain ketoacidosis, a phenomenon called intermittent cerebellar ataxia, and possibly Leaves disease. One of the current thoughts about Wernicke's disease is that it's possible to have multiple episodes of subclinical Wernicke's encephalopathy that actually collectively, cumulatively, I should say, wind up with a very severe problem. And so what may be happening is that we miss it, they have a bit of a problem, and they get better, and then this happens several times, and then finally you come in, say, with acute alcoholism, and wham, you've got it. Okay, this is an interesting case report. This was a study done in Perth, Australia. And this refers to how well Wernicke's disease is in fact diagnosed. Turns out that the results are not good. They got 131 cases of autopsy-proven Wernicke's disease. That is, they had the pathologic changes at post-mortem brain cutting. Then they went looking for the clinical record, and they can only find adequate data in 97 of these cases, and they actually compared the clinical data in terms of whether the patients were diagnosed or not. And they came up with a totally surprising thing. 80% of these people were not diagnosed in life. 80%. Now, one of the most disturbing things about it is that in 4 of these cases, these patients had all of the classic symptoms of Wernicke's disease, but they were not treated. So you got to have that clinical suspicion thing going. The other issue, I guess, is the fact that many of the patients who showed absolute evidence of having Wernicke's disease, the clinical presentations were variable. So I think we have to have basically a high index of suspicion. Remember, all you really have to have is a low thiamine access, or stress and a high carbohydrate load. And you can precipitate Wernicke's quite easily. This is the interesting one. This is a case report of a 74-year-old man who had unstable angina, who was admitted and got IV nitroglycerin. He was fine for 2 days, and then he became acutely confused, had some ophthalmoplegia, and they checked his blood level for alcohol, and found it was like 21 milligrams or so. Now, obviously, he wasn't drinking. Well, guess where the alcohol was coming from? It was the IV nitroglycerin. Okay, basically, the carrier is a combination of approximately 30% ethanol plus polyethylene glycol. And so they gave him thiamine, and within a few hours, his symptoms simply disappeared. And of course, they stopped the infusion. But this is in a case where the patient is obviously not an alcoholic, and it's also a case where this is an iatrogenic problem. In the days when they used a lot of nitroprusside, apparently this also occurred with that. So again, you just have to have this suspicion, and you have to have the high index of suspicion. You know, one of the things you can do for diagnosis is you can do thiamine levels. You can also do transketolase evaluations. These are good, but usually they're send-outs, and it takes anywhere from a week to 2 weeks to come back. That's not going to help you clinically about the guy who presents at 2 a.m. and he's confused and his eyes are crossed. So this is just another example of not being an alcoholic. Here's a case where a lady got intravenous hyperalimentation without vitamins. And on the 27th hospital day, she became acutely confused, had some ophthalmoplegia, and she was treated with thiamine, and she got all better. Again, this is essentially an iatrogenic problem. The doctors didn't give her proper nutrition. So again, you got to have that index of suspicion. And remember, when you give thiamine, thiamine is harmless. There is no record of overdosing on thiamine, ever, whether you take it PO or parenterally. So you can be very free with it. Some people are wanting to give 500 2 or 3 times a day. I personally give about 300 3 times a day in those acute cases. Oh, that's a later thing. All right, let me go through some history here, because it's pretty interesting. This is basically the history of thiamine. The foods that are rich in thiamine tend to be things like yeast, yeast extract, and pork. These are the most highly concentrated sources of thiamine. But cereal grains are also very important because of their ubiquity. And people tend to have cereal-based diets over the most part of the planet. Whole grains contain more thiamine than refined grains, and the thiamine is found in the outer layers of the grain. And in places where they polish the rice or, get rid of the hulls and things, the wheat germ and all of that, then you're getting rid of most of the thiamine. Some other foods would be oatmeal, flax, sunflower seeds, brown rice, whole grain rye, asparagus, kale, cauliflower, potatoes, oranges, liver, and eggs. Pasta and watermelon are also good sources of thiamine. The RDA in most countries is about 1.4 milligrams a day. However, there is a small-scale study where they had some female volunteers who took doses of 50 milligrams a day. Not only did they have no problems, but they all seemed to report a slight increase in cognitive ability and memory. Interesting thought. There is no tolerable upper intake level. There are, interestingly enough, antagonists to thiamine, and these occur in a variety of ways. If you look on labels, you'll find many products that have sulfites in them, and these are preservatives. The sulfites will attack thiamine and degrade it. Thiamine is also degraded by thiaminases, which are present in things like raw fish and shellfish. So if you're a serious sushi man, you might want to take a little thought about having some extra thiamine. Other antagonists include caffeic acid, chlorogenic acid, and tannic acid. So if you drink a lot of tea, you may have a little problem. These compounds basically make it difficult for thiamine to be absorbed. Let's see. Absorption. This is an important part clinically. At low concentrations, the process is carrier-mediated, and at higher concentration, it absorbs via passive diffusion. Now, alcohol blocks absorption of thiamine. So if you have a serious alcoholic who's currently drinking a lot, you don't want to give them thiamine because they're not going to absorb it very well. That's why you must give it to them parenterally. And what I normally do is I give it to them parenterally until they leave the hospital. And I had a personal experience when I was a medicine intern at the VA. We, in those days, didn't have ICU teams, so the medicine intern got to take care of all the patients they admitted to the ICU. This guy comes in, he's an alcoholic, he's kind of confused, and he's got his eyes going like this. So we put him on parenteral thiamine, and within 24 hours, that resolved. So a few days later, we put him on the floor, and I forgot to give him his thiamine. Within 24 hours, eyes crossed again. So we put him back on it, and he got better. So you have to be a little bit persistent in your use of this. A few milligrams is not going to do it. In terms of cellular uptake, the brain requires a much greater amount of thiamine than most other cells because of the blood-brain barrier tends to reduce the penetration into the brain. Okay, human storage is about 25 to 30 milligrams. And the greatest concentrations occur in skeletal muscle, heart, brain, liver, and kidneys. And there's a substantial amount in red cells. Excretion, thiamine is excreted principally in the urine. Now, thiamine has to be diphosphorylated, and for that purpose, it requires the presence of magnesium and phosphate. And you usually need kind of a fairly intact liver to do that. So when you give your parenteral thiamine, you have to check phosphate levels and you have to check magnesium levels. And of course, the drugs tend to have a lot less magnesium. So it's an important thing to do. Thiamine deficiency commonly presents subacutely, and it can lead, of course, to metabolic coma and death. A lack of thiamine can be caused by malnutrition, diet high in thiaminase-rich foods, and foods high in antithiamine factors. Anything that basically makes you seriously nutritionally compromised is a risk factor. Some people think that diabetes may also have a component of thiamine deficiency. We'll talk about a new form of thiamine that may be useful in reducing the formation of advanced glycation end products. Beriberi. That was the term for Wernicke's disease. Basically, beriberi is both neurologic and cardiovascular, and there's three major forms. Dry beriberi is just peripheral neuropathy, and you sometimes see this in people who drink a lot. I remember one of them telling me, "Gee, doc, when I'm not drinking, I still have trouble walking, and my balance is terrible." He had a pretty bad neuropathy. Wet beriberi is associated with mental confusion, muscular atrophy, edema, tachycardia, cardiomegaly, and congestive heart failure. If you're going to die from it, that's what you usually die from, is cardiovascular collapse. There's a third form that we hopefully won't see much in the United States, and that is infantile beriberi. In places where the general nutritional status is poor, thiamine intake is often pretty poor too. And so, interestingly enough, the mother doesn't seem to suffer from it, even though they tend to have low thiamine levels. But this can be catastrophic for the baby because the only thiamine they get is through the milk, and they don't get much. With them, you can have cardiac problems, aphonia, pseudomeningitic forms. You can have vomiting, tachycardia, and convulsions and death. And interestingly, following thiamine treatment, rapid improvement occurs usually within 24 hours. The improvements in peripheral neuropathy may require several months of treatment. And one of the other things is if you're nutritionally compromised and you have a neuropathy, you should always check for other causes. One of the things I find frequently is that people tend to have, as they get older, difficulty in converting folic acid to its active form, which is L-methylfolate. And the only thing you can do with that is you have to give them already transformed folate. And you can do that. There's a lot of ways to do it. You can give them L-methylfolate. There are some other preparations like Metanex and Cerebellar. And so I always, when I check for folate and B12 deficiency, I always check for methylmalonic acid and homocysteine, and we find a lot of it. Okay, let's talk about alcoholics and why they tend to have more thiamine problems. Well, first of all, they tend to have an inadequate nutritional intake. They drink their lunch and they drink their dinner, etc. Then there's decreased uptake of thiamine because active transport is substantially blocked, and liver thiamine stores are reduced because of hepatic injury. They often have impaired thiamine utilization. Their magnesium is low, and that's required for the binding of thiamine to thiamine-using enzymes, and that's deficient usually from the chronic alcohol consumption. Ethanol per se inhibits thiamine transport and blocks phosphorylation of thiamine to its cofactor form. So you have to really give it to them. You have to be sure that you check the magnesium and the phosphate. Other things. One of the things that we always think about as neurologists, if you have optic neuritis, what's the first thing that comes into your mind? MS, right? Well, guess what? You can have optic neuritis and serious optic neuropathy with thiamine deficiency. There's even 2 cases reported by, I think, Walsh and Hoyt, in a couple of children who were on the ketogenic diet for epilepsy, which responded to thiamine treatment. As far as diagnostic testing, the 2 tests that you can get are basically thiamine levels, and then you can do the red cell transketolase. I think probably the red cell transketolase is probably a little bit better. But again, it's not going to help you in the acute problem because it's a send out and you don't get it back. Let's talk a little bit about history. This is an interesting little bit of anecdote. In 1884, Kanehiro Takaki was a Surgeon General in the Japanese Navy. There had been a problem with beriberi, and a lot of Japanese sailors died on long sea voyages. This occurred all the way up to and including the Russo-Japanese War of 1904-1905. He hypothesized that the disease was due to insufficiencies in the diet. So he did an experiment. He took 1 ship and he changed the diet from mostly polished rice to pretty actually good diet. His thought is that it was primarily because of the decreased amount of nitrogen in the diet, which is not true. But what was interesting is that when he substituted the better diet, the beriberi disappeared. Now, we're talking about people dying on the ship, okay? It happened frequently. Well, the Japanese Navy decided that that was way too expensive and the sailors weren't worth the money. So they went back to the polished rice thing and they continued to have problems. However, in 1905, the anti-beriberi factor was discovered in rice bran and in brown barley rice. And so at that point, that was substituted into the Japanese Navy diet and the beriberi disappeared. He was subsequently rewarded by making him a baron in the Japanese peerage system, and they called him the barley baron. The specific connection to grains made in 1897 when they discovered that fowl fed on a diet of cooked or polished rice developed paralysis. Then there was a connection interpreted by Gerrit Griggens about the connection between excessive consumption of polished rice and beriberi in 1901. He concluded that the rice contained an essential nutrient in the outer layers that was removed by polishing. It wasn't until about 1911 that Dr. Funk isolated what he called the antineuritic substance from rice bran, which he called a vitamine, which is basically something that was vital and was an amine. So that was the first vitamin. And it today is in fact vitamin B1. Let's see. The substance was actually isolated and crystallized in 1926. And then in 1936, thiamine was synthesized and it was able to be used for treatment. So all this time, going back to the time when Wernicke described his index cases, people thought that it was mostly an inflammatory disease. It was invariably fatal. It turned out that the treatment and prevention was incredibly cheap and available to everyone. Originally, it was called A-neurin for antineuritic vitamin. A lot of animal research was done with that. Okay, now we want to talk about, I guess for the last part of this, there's another form of thiamine available. Thiamine is a water-soluble vitamin. This one is a lipid-soluble vitamin, and it's similar to thiamine in all of its functions. It's called benfodiamine, and it was originally licensed in Germany in 1993. Turns out that overseas they do a lot of supplementation for treatment of things like neuropathies. Now, the most interesting thing from our standpoint is that there was a small-scale study where benfodiamine lowered the advanced glycation end products by 40%. Now, this is a big deal for diabetics because the damage is usually mediated by the advanced glycation end products. So here you have something that's cheap, harmless, and widely available that could conceivably improve the outcome of diabetics. I use it in my diabetic neuropathy, so in combination with a couple of other things. I usually add some pyridoxine, no more than 100 milligrams. And it's important to remember that pyridoxine is very funny. You can have a pyridoxine deficiency and get a neuropathy. If you have too much pyridoxine, usually over 500 milligrams a day, you can get a neuropathy. But we do use it. And we use alpha-lipoic acid. The combination is rather interesting. Most of the time when you see somebody with a diabetic neuropathy as a consult, they want you to just help the pain, which we can do most of the time. But we don't really do much about the actual problem. I usually check for other causes because you can have as many diseases as you want. And we treat those if we find them. But aside from controlling the sugar by controlling your carbohydrate intake, this actually seems to be a little bit of a cocktail that seems to help the neuropathy itself. So it's interesting that this stuff is around, it's been around, and nobody seems to be interested in it. Well, that's pretty much all I had to say. Do you have any questions or thoughts about all this?
So, how, I mean, when you talk about the Japanese diet, it's basically all of the things that have thiamine stripped away from them or didn't have it in the first place. So what's the modern Japanese approach?
Well, I think the
Is
diet
there
in
enough in
Japan
vegetables?
it has now improved to the point where it's not just rice.
Right.
In the old days, people were really poor, and rice was primarily what they ate. But now, as you remember, things like meats of various kinds, grains of various kinds, do have a lot of thiamine in them. And if you don't drink much, you don't have one of those genetic issues with the thiamine transport, then you don't get it. Yes,
Well, I've always wondered, thank you, very nice lecture, about polished rice. And polishing obviously involves some extra work.
yes.
So polished rice, I mean, does it taste better theoretically than unpolished rice?
I don't know. I think it's a cultural issue, and it may also have been a storage issue. When you have unpolished rice, there's oil in the bran. And what happens is the oil can get rancid in storage, and then you've lost your food. But if it's polished, there's basically just nothing but carbohydrate and maybe a little bit of protein in it. And so that doesn't spoil anywhere near as well. Yes?
Have you come across this type of deficiency could be a risk factor to motor neuron disease?
I haven't seen anything about that. Dr. Bertarini in our group runs the ALS program in Memphis, and he's never mentioned anything like that.
There were a couple of reports that they describe patients with ALS, they have deficiency or low level of thiamine.
Well, there are obviously going to be some people who are nutritionally compromised, and you're going to have low levels of thiamine.
Yeah,
That doesn't necessarily mean you got it.
Yeah, that probably could be a consequence of they are not eating as much. And
Right. If you stay to the point with ALS where you can't swallow, you're going to be severely nutritionally compromised. Most of them get really thin as they go to the end.
And just in this compound, vitamin, my previous mentor, Flint Beal in New York, they just did a study, they haven't published it yet, by the way, that they used it in mouse model of tauopathies.
I'm sorry, say it again.
Mouse model of tauopathies.
Uh-huh.
And he tells me that those mice benefited from that.
Uh-huh.
Tauopathies, normally, they actually lose a lot of motor neuron as well. And so I wonder if you have any comments on that or any...
I don't know really much about that.
All right.
It's interesting, I kind of stumbled on this stuff when I was just kind of researching different things about thiamine. And I started looking at it, and then we see a ton of diabetics who have neuropathies, and I like to try to give them something that's safe, harmless, and over the counter. And if I can help the neuropathy itself by doing this, then I'm all for it.
Did you find anything about why the particular sort of subcortical nuclei, the oculomotor nuclei in particular, are particularly vulnerable to?
I'm not sure why. It tends to be sort of like a midbrain kind of a problem. Right. And you can have involvement of all of those structures in there. I'm not sure why you get that problem, but if you look at pathological specimens, periaqueductal gray is involved. It tends to be sort of a little hemorrhagic kind of thing. You can see it sometimes on MRI scans, although you don't always. And I'm not sure exactly why. It probably has something to do with the metabolic demand, because what this does in essence when you're thiamine deficient is it impairs your ability to utilize carbohydrate. And the brain's primary fuel is, of course, glucose. You can use ketone bodies if you get into a starvation state, but it may simply be that. There are a number of areas in the brain that tend to be particularly energy requiring. Then there are other states, for instance, when you have a seizure is an intense energy requiring event.
One way to think about it is as an acquired mitochondrial disorder, basically.
Could be. But the basic thing is, let's go back if I can get to the. I'm not really good at this. Let's see. Yeah, the things to remember. And although most of your patients will be alcoholics, some of them will not be. And the thing you particularly don't want to do is you don't want to have an iatrogenic cause for it. Remember that they don't necessarily have the classic symptoms or signs, and that your level of suspicion based on risk factors is probably what's going to guide you in terms of giving the drug. Why call it a drug? And you can't hurt anybody with it. It's cheap. It's harmless. It's available everywhere. We ought to use it. Then, of course, there's evidence that Wernicke's disease is markedly underdiagnosed. And that shouldn't happen. Particularly shouldn't happen in a patient who has all the classic signs, which apparently occurred in 4 of those patients.
Just a side note, Dr. Lucy does a lot of testifying in, and I would bet you that he has seen cases where neurologists have been sued, because I got called in to testify, or at least render opinions once, on neurologists who fail to diagnose and treat, because this is a treatable, preventable problem.
Yeah.
But only if you diagnose it in a timely fashion.
Absolutely.
And so this is one of those things where, that's why the knee-jerk response, somebody comes in encephalopathic, is you give them thiamine because you will never hurt them.
That's right.
And if you can prevent a case of Wernicke's or Korsakoff syndrome, you've done a good thing.
Absolutely. And in the emergency room, one of the protocols for somebody who comes in is Narcan, D50, and thiamine. Hopefully the thiamine first. Yes, sir.
Do you think we're under-treating some of these?
No question about it. Absolutely. And it's cheap. It's harmless. It's
But as
available
far as,
everywhere.
even as far as dose, when we do identify somebody, do you think sometimes we just don't give enough?
Yeah, and sometimes all they get is 100 milligrams of thiamine. If it's an alcoholic, this just ain't going to get it. Yes, sir.
Well, people have talked about putting it in alcoholic beverages.
Oh, yeah. There was a paper about that, actually, and they went through the economics of it, and they said, well, it'll save X number of millions of dollars from people having Wernicke's problems. But no one ever has done it, and I'm not sure why. There seems to be some constitutional thing about forcing people to take medicines against their will or something.
But they do it in Wonder Bread. I mean, it's and it's the same philosophy that you take this very polished bread product where you stripped out everything that's good, and then you add back this big horse pill of vitamins into the mix so that you
all of that.
have it back.
Actually, I have a better idea. I think it should be put in soft drinks, because soft drinks cause more nutritional problems in the United States than alcohol does.
Everybody thinks now that fructose is poison. If you drink a Coca-Cola, you drink 40 grams of fructose, because it's in everything. I mean, corn syrup is just everywhere. And there's a lot of reasons to think that it's a bad thing. For instance, you can actually buy Mexican Coca-Cola. It's made with sugar. At Sam's. People who don't like the fructose.
Still in a glass bottle.
Yeah.
Interesting, the contributions of sailing to medical history. The Brits, it wasn't until there were long voyages and you had to rely not on any fresh vegetables, and it was until they figured out that fruits, in particular citrus fruits, had vitamin C, that they would lose half their crews to scurvy.
Absolutely.
And it took a while, and there were all these thoughts about what the right antiscorbutic agents were, and they sort of figured it out and lost it several times. There's some really interesting historical accounts of how the correct treatments for scurvy were discovered and then forgotten several times before people figured it out.
Yep. That's why they call them limeys.
Yep.
Yes, sir.
Another thought, all these Navy issues, you think they'd be able to fish, and fish probably have a lot of these things in them.
You would think, but maybe they didn't. I don't know.
You're in the middle of an ocean, for God's sake.
You got fish, right?
questions? Well, thank you very much. That was great.
Okay. How are you?
I hope you're doing well.
Happy birthday. It is your birthday.
Thank you.
I was taking my daughter to college.
Well, that's important. After the number I have, my birthday is
When she left, so she realized she said there was also a number of price.